I'm Dr. Fakir Abadi, and this is Clostridioides difficile infection in adults. Clostridioides difficile, or C. diff, was formerly known as Clostridium difficile when nomenclature changed in 2018. C. diff is a gram-positive anaerobe, and it has two important characteristics. The first one is that it's spore-forming. It can survive in aerobic conditions by forming spores, and alcohol rubs are ineffective against spores, which makes washing hands with soap and water extremely important. Spores are stable in acidic environment as well, such as the stomach. The second aspect of C. diff is that some strains are toxigenic, meaning that they can produce toxins. Specifically, C. diff, toxigenic C. diff, can produce toxin A and toxin B. And I'll explain what the consequences of these toxins are. C. diff infection is extremely important because it is attributed to extreme healthcare costs, as well as 5% infection-related mortality and 15 to 20% all-cause mortality. In fact, the CDC has classified C. diff as an urgent level of threat because of its prevalence and associated death. Although the rate of C. diff has been going down in recent years thanks to antimicrobial stewardship efforts, the annual cases requiring hospitalization are still in excess of 200,000. Now, to demonstrate how prevalent C. diff is, you can see the rate of C. diff on the left-hand side compared to the rate of ESBL infections, which is much more common than multi-drug resistant Pseudomonas, which is more common than carbapenem resistant Enterobacterales, which is more common than carbapenem resistant Acinetobacter. So you can see that C. diff infection is a serious infection that's very prevalent. And to make things worse, it is also associated with increased rate of death, and you can see that the rate of mortality from C. diff is significantly higher than mortality due to ESBL infections, which is significantly higher than multi-drug resistant Pseudomonas, which is higher than CRE and CR Acinetobacter. Let's take a look at the pathophysiology of C. diff infection. It requires both acquisition of C. diff as well as disruption of the gut microbiota, because the gut microbiota has a protective role against C. diff. Although the exact mechanism of symptomatic infection is unclear, toxins play an important role. The toxins produced by C. diff can disrupt the epithelial cells inside the GI tract, which can result in release of inflammatory mediators, and this immune response can be severe in many patients. In fact, the clinical manifestations range from diarrhea to pseudomembranous colitis to toxic megacolon, colon perforation, and death. As I mentioned, the healthy gut microbiota have protective role against C. diff. When patients are exposed to antibiotics, the normal gut microbiota is disrupted. This leads to decreased species abundance as well as decreased diversity in the gut microbiota. In patients with disrupted gut microbiota, the C. diff spores find the opportunity to germinate to vegetative cells, and then they can grow and dominate the GI tract. And then once C. diff colonizes in the colon, some patients may remain asymptomatic. That depends on whether their immune system will respond to toxins produced by C. diff. For some patients, these toxins will induce an immune response, and depending on the severity of the immune response, there can be serious consequences, such as hypotension or shock, ileus, or toxic megacolon. These patients are the most difficult to treat and have the highest risk of mortality or need for surgical intervention to manage CDI. When patients receive treatment with antibiotics for C. diff infection, the clinical symptoms will be resolved. Over time, the healthy gut microbiota will be restored, protecting the patient against future C. diff recurrences. However, if the gut microbiota continues to be disrupted, then the patient will be at risk of getting recurrent C. diff infection. About 94% of C. diff infections are acquired in the hospital. So in a C. diff negative patient who's hospitalized, they can be colonized by C. diff. Now, not every strain of C. diff is toxigenic. So some of these patients will be colonized with a non-toxigenic C. diff, meaning that the C. diff will not produce toxins. So these patients will be asymptomatically colonized with C. diff. And then there are patients who will be colonized with toxigenic C. diff, and they will have immune response to these toxins. And these are patients that will be either symptomatic or asymptomatic. And whether they're symptomatic or asymptomatic depends on the immune system of the patient. So whether their immune system responds to these toxins, or if their immune system does not respond strongly to the toxins. Now let's take a look at reliable resources. There are several guidelines out there. So there is the 2013 guidelines from American College of Gastroenterology. So because C. diff infection involves the GI tract, so GI doctors, gastroenterologists are involved with the management. So ACG has guidelines that last updated in 2013. And of course, this is an infection. So we also have the IDSA and SHEA guidelines that were updated in 2017. And most recently, there are American Gastroenterological Association that has guidelines for the use of probiotics, which we will not get into in this topic, but is available for your reference. The first learning objective is describe the PK/PD properties of antibiotics used for CDI. Metronidazole essentially disrupts the DNA and inhibits nucleic acid synthesis. It is available both as IV and PO. Note that with the PO, it is 80% bioavailable. Now for CDI, the site of infection is actually in the GI tract. So it's actually best if the drugs are not absorbed, because when they are absorbed, they go away from the site of infection. So when 80% of oral metronidazole is absorbed, about 20% of it stays in the site of infection. And of course, with IV, 100% bioavailability means that the entire drug goes into the bloodstream, and then a portion of it may actually go from the blood to the GI tract. One adverse effect that's unique to metronidazole is that the patients might get metallic taste. Now, this is specifically with the oral formulation, not with the IV. For vancomycin, we have two oral vancomycin formulations. So we have vancomycin, which is basically a capsule, and we have more recently Fervanc, which is an oral solution. Now, because these oral formulation of vancomycin are very expensive, we actually in the hospital, we can use the IV formulation of vancomycin as oral, because the IV formulation, which is meant for injection, is quite inexpensive, can actually give it orally. But regardless, for treatment of C. diff infection, vancomycin must be administered orally. So IV vancomycin as an injectable is not an option. And this is really important because pretty much less than 1% of vancomycin is absorbed. So it actually stays at the site of infection. So this is excellent. Now we also have fidaxomicin, which is available as an oral tablet. This also does not get absorbed, so it stays at the site of infection. We also have rifaximin, which is also not absorbed. And more recently, we've had bezlotoxumab, which is a human monoclonal antibody, which basically binds to the toxin B, and it prevents the toxin from having its effects on the cells. And this is specifically IV, and I'll explain more about this. Now, one thing that's important about bezlotoxumab is that heart failure was actually reported more commonly in the patients that received this agent, in patients with a history of congestive heart failure. So in patients with a history of CHF, bezlotaxumab should be reserved for use when the benefit outweighs the risk. And this is from the package insert. Now I want to draw your attention to the fecal concentration of these drugs because the site of infection is in the GI tract. You will see that because oral metronidazole is mostly absorbed, you get the significantly lower concentration in the feces, and this is in microgram per gram of the feces. Whereas with vancomycin and fidaxomicin, you get significantly higher concentration. So I want you to keep that in mind when we talk about the efficacy of these agents.